Great. So thank you very much, Julie, for the introduction. I'm Gary Ewart, staff of the American Thoracic Society. As background, the American Thoracic Society is a medical professional organization of physicians, scientists, respiratory therapists, and nurses dedicated to the prevention, treatment, and cure of pulmonary disease, critical care illness, sleep disordered breathing. In short, we're the lung docs. And the sleep mission is an important part of the three pillars of our organization. And I have to say, Julie, you oversold me, because all the presentations today, from the patients to the clinicians talking about the exciting research and the use of better tools for screening in physician encounters, has been very exciting. And I'm going to talk about boring CMS policy. So I would probably be the least welcome guest at your dinner party, but I'm glad I'm invited to the table. So with that preface aside, let me talk about a CMS policy that has created significant barriers to patient access to good sleep health and good sleep care. So in 2008, Medicare mandated that beneficiaries who are prescribed CPAP and other positive airway pressure devices have to demonstrate at least greater than 4 hours a day of use for 70% of days over a continuous 30-day period within the first 90 days of receiving the device. Now, that three-step test is hard enough just to understand, let alone to implement, but essentially saying if you're a Medicare beneficiary and you have been prescribed CPAP or BiPAP for OSA, you have to prove that you're using it. In one sense, this policy makes sense because Medicare is in the business of being good fiscal stewards with taxpayer dollars, and it is in their responsibilities to make sure that if a Medicare service is being ordered, that it's actually being used. And with the advent of telemonitoring and with these devices able to track how much they're used and report that back to the prescribing clinician, it has enabled us to physicians and clinicians to know with some precision whether patients are using it or not. For those who don't meet this criteria, essentially they lose the machine, and the only way to get it back is they have to go back to their prescribing clinician, retest, which is a significant barrier for anyone who wants to continue to use a device, but poses particular barriers for those who are low income or marginalized population. Just think of the time of clearing your schedule of getting to the doctor's office and the copay associated with that, and scheduling another visit. And it's not as though your diagnosis is going to change with that retest. Assuming it was properly diagnosed the first time, you're probably going to still have the same sleep disorder breathing issue you had in subsequent retesting. So we know this actually is a problem. And I'm not going to go through each of those slides, but each of those points on the slide, but there's well-documented evidence that says that if you are low income, or live in socioeconomic areas that have low income, you are less likely to be adherent to use of CPAP machines compared to those who are in higher socioeconomic neighborhoods. That also overlaps with underrepresented minorities also having less adherence to use of CPAP for OSA. Doesn't mean it's not being used at all. It just means it's being used less frequently than those who have greater wealth and greater access to other conveniences that make life just a little bit easier. So Medicare has essentially created a policy in their desire to be good stewards of the public dollar that is creating a barrier to care for all patients, but a unique barrier to care for those who are low income or underserved. Essentially, it's a barrier to health equity. So what are we doing about this? So the ATS has been aware about this and has been concerned about it for quite some time. We recently held a workshop where sleep experts got together, reviewed the available evidence that both reviews the policy, takes a look at the studies that show that this policy is creating real barriers to care for Medicare beneficiaries. We're putting together a position paper that outlines both the problems that this policy causes and our recommended solutions on how CMS can change the policy while still being good stewards of the public dollar, but being reducing or hopefully eliminating this as a barrier to care for patients across all Medicare beneficiaries, but particularly addressing those barriers that are caused for those who are either low income or come from minority communities or underrepresented communities. We're hopeful that this administration will be particularly sensitive to this because the Biden administration, I think, has gone to great lengths to show that they are sensitive to health equity and health equality. And because this issue touches directly on health equity and health equality, we are hopeful that they'll be sympathetic to both the problem that we're presenting to them and would be willing to work with the ATS and our sister organizations on how to solve this in a way that is good for patients, good for sleep health, and good for better lives for us all. With that, I would pause for questions and discussion. Not nearly as exciting as patient stories, but this is the kind of barriers that clinicians and patients have to deal with. And if we can change it, it will make getting the tools, the successful tools that we know can work, out to a broader patient population who will benefit from this care.
Thank you, Gary. I think there's some great discussion happening on the questions over on the chat. And I think you also, I don't know, I'm sure Dr. Maltor will address this as well, but could you just give us a quick update on telemedicine too, and where that is by any chance of efforts to continue telemedicine from here?
Sure, I'm happy to talk about that. So as you know, during the COVID public health emergency, CMS significantly liberalized their ability to allow clinicians across all specialties to use telemedicine. This was a COVID forced change in policy. The telemedicine had been around for decades, but all of a sudden we had a public health emergency and everyone started to use it. And all of a sudden everyone's decided, you know, hey, this is actually kind of nice. It is nice from the patient perspective. For example, during COVID, my wife had severe stomach pains. And as a result of a scheduled that day televisit with her provider, said, you probably have an appendectomy problem, sent her to the office visit. 10 minutes later, she was in the hospital for a near emergent surgery for her appendectomy. Had we not had that easy option of doing that televisit that morning, we probably would have delayed care by a couple hours or more, which would have turned a semi-emergent situation into an urgent situation. So I am personally grateful for what telemedicine is able to do. And there are a lot of stories about how this just adds convenience to both the patient and the provider. One of the challenges, just because it seems easy in the interaction, doesn't mean it's easy from the provider side. Particularly Medicare beneficiaries who may be older and don't have access to smartphones and laptops and are not facile with internet use and all that. It requires more staff time in some cases for physician office staff to schedule, prepare for, test the connection, a virtual meeting than it does actually an inpatient clinician meeting. So how we value this, when I say value it, how much does it cost? How much is Medicare going to pay for it? Is something that both the clinician community and CMS is wrestling with. But I think that the COVID-driven advent of telemedicine is here to stay. What we're still trying to catch up on are what are the policy procedures to both decide when it's appropriate to do telemedicine visit and when an inpatient visit is required. How do we reimburse these? And how do we track them? Because I think we'll find over time that collecting data on these visits, probably through a coding modifier, will provide useful information both on the quality service and how to reimburse them. We're in the process right now that CMS has still declared that we're in a public health emergency. So the liberalized policy, both for telemedicine visits, supervision of services can be done remotely. And there's an ongoing dialogue between CMS, the provider community, and private health insurance, as well as what is the telemedicine world going to look like after COVID. So that's a long-winded way of saying it started, it can't go back. We're not quite sure how it's going to go forward, but we're working on the answer now.
All right. Well, I like that. We need that honest answer, and that's very helpful and very encouraging. So let's hope it never goes back to the way it was. I hope your wife is doing well. It's a
success story. Thank you.